So now we're going to continue on. This is still part of threats to neurosensory. But we're going to start talking about head injury, and then we're going to go into brain tumors at the end. So head injury is basically any trauma to the skull, the scalp, or the brain. Sometimes you'll hear it referred to as a serious head injury. It's called a TBI, or a traumatic brain injury. And it's just a serious form of head injury. Yeah. Well, you know, you can get a laceration, a mild concussion, those kind of things. Right. And then it can be more serious, and they call it a traumatic TBI. There's high incidence. 1.7 million people are treated and released with TBI. That's a lot, huh? And then, I don't know, this might not be exact, but around 5 million people, so about 2% of the population currently live with disabilities resulting from a TBI. Yeah, 2% of the population. And, of course, it can be caused from several things. Often you will see people, you know, impulsiveness, jumping off bridges, jumping off, oh, let's get on the roof and jump into the pool, that kind of thing. Or let's go dive off of this rock and we don't know what's down there. So it can, you know, all kinds of things. Motor vehicle crashes, assaults, sports. Think about your football players, your boxing, soccer. So recreation and sports. And of course, war is also listed. When you're at war, you can get a head injury, of course, right? Males are twice as likely to sustain a TBI as females. Hold my beer. Watch this. But there's a high potential for poor outcome because the brain is very sensitive. We already talked about it's not very compliant. And deaths occur at 3 points in time after the injury. So immediate, a direct head trauma, or a massive hemorrhage. So it could be pretty immediate. Within 2 hours, so you got a head injury, you got a brain bleed, internal bleeding. So, you know, ever how long it takes you to bleed out. 3 weeks. That can be like more of a multi-system failure. Patient goes into the hospital just with a concussion, and then they weren't in very good health before they went into the hospital. So they, you know, multi-system failure can happen. And there's diffuse versus focal. So diffuse is the whole brain is shaken up. We're going to talk about that. Versus focal, so one area of the brain, like a hematoma. And they can be minor, moderate, or severe. Your focal injuries, like your contusion or your hematoma. And like I said, we're going to break it down even further. So basically, the scalp laceration, I started to take this slide out because it's a really short slide. That's it right there. But that is a form of head trauma, right? Head injury is an external head trauma from a laceration. It can cause blood loss. It can cause infection. You know, infection can lead to all kinds of problems. So I left this slide just because, you know, it is important. It's part of it. Often, you know, the scalp is very, very, very easy to bleed, right? I was younger. Me and my brother was in a little kiddie pool. I think he was little and I was a little, you know, maybe 5 or 6. And he's got this pot, terracotta pot that he's using water, and he hits me on the head, and it hits right there. And all of a sudden, blood's just, you know, going down my face, and it freaked me out because there's a lot of bleeding there, but it's just a tiny little. My mom didn't take me for a stitch or anything. Just held pressure and it stopped. So, you know, you can have just a small scalp laceration and have a lot of blood. Just because it's very, what's the word I'm thinking of? All right, so let's get into fractures. I think it's on page 1326, if I'm not mistaken. Sometimes I look on my phone and it's like a different page than the actual book. I don't know why. So, there's different types. You got your linear, which is like a depressed and an indention, right? It can be simple or comminuted, and that's just fragments. Comminuted just means there's fragments there. So comminuted compound just means there's fragments, and then closed or open. Often, if there's fragments involved, they need a craniectomy. They got to go in and get all those fragments out. So they'll do a craniectomy. Complications, of course, infection, hematoma, tissue damage. So you've got your raccoon eyes. If you've ever seen anybody, so you got your periorbital edema. So often that happens when there's a head injury on the top of the head or the frontal, because blood drains, right? And it kind of sits there. And then you have your fracture at the base of the skull, which is called the battle sign. Right here, that's your battle sign. I'd know the difference between those. And then the battle sign. And so often when you get these fractures in your skull, you have a leakage of CSF fluids, right? So then you can have the rhinorrhea or the otorrhea, right? Where you're draining out spinal fluid through your nose or your ears. So what's the first action if you see that?
Cause.
No. The dextro sticks. That's what your book says. So your book says use the dextro sticks. So I want y'all to remember that. You would use your dextro sticks first and then your gauze.
For drainage.
Mm-hmm. Because as nurses, we want to use gauze, right? We want to sop it up.
I just think if you're sitting on a neuro floor, I'm just sitting and you try until you're waiting.
Yeah. So what about the treatment? Well, if it's just a minor fracture, then it's conservative. You're monitoring the patient. But if it's depressed or comminuted, which means the fragments are in there, then they're going to need a craniotomy. Because you have to elevate the depressed bone and remove the free fragments. If a lot of the bone is destroyed, they may have to do a craniectomy, which just means part of the bone will have to be removed, and a cranioplasty may have to be performed later, at a later time. So as far as diffused, it's just a concussion, right? So somehow the brain's just basically kind of shaken up. So they call it diffused because the whole brain is affected. They may have a brief disruption in level of consciousness with a diffuse injury. They can have retrograde amnesia. So if you've ever had a car wreck or hit your head in a car wreck and you lost consciousness and couldn't remember what happened for just a minute, you probably had a concussion or a mild concussion, or can be worse. You may get a headache, of course. Anytime your whole head is shaken up, you might get a headache. Can be a short, your clinical manifestations, there in green, can be short duration. So it may just last for a little bit, depending on the degree of the concussion. And then sometimes they can get post-concussion syndrome. Do y'all know what that is? Well, yeah, they're seeing that sometimes with your sports, where they've gotten, soccer player or whatever, and all of a sudden they can't focus at school. They may even have a change in personality because of the continued concussions that they're having, the brain injuries. They call it post-concussion syndrome. I think there was a 60-minute or some kind of documentary on a football player that had it. Headache, HA. I don't always do it, but I try to write my clinical manifestations in green. Sometimes I forget. So sometimes with post-concussion syndrome, they'll have these behavior changes. They'll have a persistent headache, decreased attention span. So all of a sudden, they didn't have ADHD, but all of a sudden, it's like they can't concentrate. Decrease in short-term memory, change in intellect. They were a straight-A student, and all of a sudden, they're failing or having, C's and D's.
Bring her to Trinity because they would have given you that for free and sent you home.
Really?
Yeah, Trinity's hospital's the only one that'll do that, but they'll look at you and give you
Assess
a quick
you?
one-over, and if you're not in any type of issue, they will send you off without billing you.
Oh, wow. That's amazing.
Yeah.
Yes.
So when we were in Burgess's,
So, as far as a treatment for a concussion, if there's no change in level of consciousness, or they lost consciousness for less than 5 minutes, they just observe them. But with my niece, how do they know how long she lost consciousness for? They weren't there during the wreck. And so I was a little upset about that, but she was okay. She's okay. So, no loss in level of consciousness or loss of consciousness, then they just observe. That's why they say watch them. Any vomiting, any you want to see them walk, make sure they're walking straight. Any change in level of consciousness, any of that. That's why you watch somebody after they hit their head, because you want to see any changes. All right, so let's talk about a contusion. So a contusion is bruising of the brain tissue, right? Contusion. It's often associated with a closed head injury. And this picture, this contra coupe, is one of the ways a contusion can happen, but it's not the only way. It's just a picture here of this, because it could be any kind of hit on the head, not necessarily just this contra coupe. So any kind of bruising of the brain tissue. A hematoma becomes a space-occupying lesion, so occupying the space of the brain. So as far as clinical manifestations, what are you going to see with these patients? Well, a hemorrhage. They could infarct, the brain tissue could infarct. Necrosis, brain tissue could die. And it can even rebleed. Edema, swelling. They could get seizures. They could increase risk for hemorrhage if they're on anticoagulants. So think of your elderly, they're on Coumadin. So increased hemorrhage if on anticoagulants. So within the first 7 days, seizures is a common complication. Again, your anticoagulant use can increase the hemorrhage, so they could have a more severe head injury or complication. So all falls should be assessed. That's why your history is so important when you're, doing intake. So as far as your treatment, it's conservative. Depending on the severity. Of course, if they're on anticoagulants and they're bleeding, I have to do a little more, but definitely anti-seizure meds, monitor ICP, GCS, neurochecks. They may even, depending if it's bad enough, they may have to evacuate the hematoma and pull it out. Because the hematoma becomes a space-occupying lesion. And back to our ICP, what do we want to do? We want to treat the underlying cause. And if that hematoma is occupying that 100% area that your Monroe-Kelly doctrine, then you got to get that hematoma out. Surgically, yep. Treat the underlying cause. All right, so now we're going to talk about hematomas a little bit more. When we talked about the contusion, you got your contra coupe, which is basically a hematoma that you hit it forward. Sometimes you hit it forward, hit it backwards, so they'll get hematomas. So primary impact, secondary impact. You got your wall there. They'll hit it. This happens a lot during like a motor vehicle crash. They'll hit the front and hit the back, or slippery slides. I've seen somebody do that. They were on a slippery slide and they hit it frontward and hit it backwards.
I'm sorry, back at the top, what's that word
Under hemorrhage?
Infarction.
Okay.
Hemorrhage, infarction. All right, so I'm going to push play here, and it's going to show you it's just going to outline the dura of the brain. Okay, so the yellow is your dura of the brain, and it's attached to your skull, right? So this one over here on this side is your epidural hematoma. So you see how it's above the dura. Then your subdural hematoma is below, so sub below, right? The dura is attached to the skull. That just says the dura is attached to the skull. And your epidural hematoma is your bleeding between the dura and the skull. This is a neuro-emergency, neurological emergency. It could affect the venous, which would be a slow bleed, but it could also affect the arterial, which would be a fast bleed. Often, you know, they say the temporal, if somebody gets hit in the temporal area, it's not a good place because there is an artery there that can cause a fast bleed. So your clinical manifestations is you're going to have initial change in level of consciousness, and then they may have a brief lucid period where they're just everything, their level, they know the year, they know it, you know, they have a good LOC, and then their LOC goes down again. They may have headache, nausea, vomiting. They can deteriorate pretty fast if it's arterial. And the treatment for that is for the fast arterial bleed is a rapid evacuation, craniotomy, or a burr hole. You know, they'll poke a hole and drain that blood. The size of the hematoma impacts the prognosis, which makes sense, right? If it's huge, it's not as good for the patient. So your subdural, bleeding between the dura and the meninges, usually it's venous. You got 3 types: acute, subacute, and chronic, and we're going to talk about each one. So your acute subdural hematoma is usually 24 to 48 hours after injury. You're going to see increased ICP, headache. Sometimes you'll see the ipsilateral dilation, where the side where the hematoma is, the pupil will be blown or larger than the other. And that's an acute bleed. You'll start seeing this stuff 24 to 48 hours after injury. And then your subacute can go 2 to 14 days. The bleed enlarges. So this is your patient. They were in the hospital, came to the hospital, they had a bleed. They didn't think it was that bad. They sent them home, and they came back to the hospital because they were not doing well. So this could go over a 2 to 14 day period. And then your chronic subdural hematoma is your older adults, your alcoholics. Why do you think that is? Why do they call it chronic? Yeah, it can be misdiagnosis because what are your older people? They think, oh, they have TIAs, they have, you know, different things like that. And so the same thing with your alcoholics. They misdiagnose them all the time. And as the brain atrophies, your your brain's attached to your dura, it's easier to tear because of the atrophy. Chronic, weeks to months. Yeah. So weeks to MO. It can happen over weeks to months. So you just got this slow growing bleed. So you got this patient, this alcoholic, came to the hospital. They didn't really find anything. Sent them back home. 10, 15 days later, they collapse on the floor. So your subacute, confusion, lethargy, memory loss, all of those things that a lot of times the elderly and the alcoholics have anyway. So that's why it's so hard sometimes to get this. Then your intracerebral hematoma, just bleeding within the brain tissue. It can be frontal, temporal lobes. The size is the size of the bleed is the patient's outcome. If I was going to focus on something, I'd focus on my epidural, my subdural, though. All right, I'm going to have to go fast so we can finish up, and then y'all can go back and listen to it if you want to add in stuff. But you don't have to write anything here. Your diagnostics are CT scan. That's the best diagnostic to determine the cerebral trauma. MRI, PET scan, transcranial Doppler studies, cervical spine x-ray, and your GCS. So all these are your diagnostics. Your treatment principles, you want to prevent secondary injury. That's the whole purpose in your C-spine and keeping the spine straight. And you want to prevent that secondary injury. You want a timely diagnosis. Time is tissue, right? Time is brain. Surgery if needed. So if they need that, evacuation. Collaborative care, emergency treatment, patent airway, GCS less than 8, intubate. C-spine, we want to control the spine, right? Because increased flexion of the neck, increased intracranial pressure. Oxygen, non-rebreather. You want a non-rebreather, you want IV access. A lot of times you will administer fluids or whatever. You want to administer cautiously because you don't want to throw off, too much fluid too fast. Control external bleeding. Maintain warmth. You want to monitor your vital signs. Monitor for PE, pulmonary embolus. Oh no, physical assessment, excuse me. Definitely prevent pulmonary DVT, which could turn into a pulmonary embolus, but this means monitor your vital signs in your physical assessment, physical exam. These are your nursing diagnoses. I won't go through all of those, but if you're, you got a patient that you're going to do your care plan on, this could be helpful to refer back to this if you've got any kind of brain injury patient. And then as far as your overall goals, you want to oxygenate your brain tissue, right? You want to perfuse it. You want to keep them normothermic, normotensive, so you want their temperature and their blood pressure as normal as it can be. Control pain and discomfort. This just says the normothermic 100.4. You want to keep their temperature. You want to keep them, control their pain and discomfort because pain also increases the ICP. free of infection, adequate nutrition. You want the maximal cognitive, motor, and sensory. And this is kind of just your, kind of redundant, I guess, because we already talked about this, but this is just more of a bigger picture, I guess. You're always trying to keep it from getting worse, right? If it's bad. So maintain cerebral perfusion, prevent ischemia, monitor your change in your neural status. You want to teach your family about monitoring those things. They might need eye drops if they are, on a vent or in a coma. Maintain normal temperature. You want to prevent shivering. Why do you want to prevent shivering? It increases ICP and they're in a hypermetabolic state, yeah. If they're leaking CSF, definitely no sneezing, no NG tube, no blowing. Increase the head of the bed, but you never want to go too far, too high, right? 30. Your measures for an immobilized patient: bowel and bladder, skin, antiemetics, analgesics, because you want to prevent them from vomiting to prevent increased ICP. So they might need antiemetics. And then your long-term motor and sensory deficits. Their family, you want the family to participate because, they may have to learn sign language or, just different things. So definitely get family participation as far as communication, memory, intellectual functioning. One of the consequences of TBI is that the patient may not realize that the brain injuries occurred. They've been comatose. They may suffer a personality change. All this, the family needs to be counseled on all this. This could happen. They may not be the same person to them, So that's why the family involvement is so important. Nutritional status, we already talked about that. That's very important. Because these patients often, they may go to a long-term facility or they may go home and their family's taking care of them. They may need bowel and bladder management. We'll talk more about that tomorrow when we talk about spinal cord, but they may need, those kind of bowel and bladder training, seizure monitoring, and definitely mental and emotional difficulties. Like I said, they may not realize what happened. They may have mood swings, apathy, euphoria even. So all of these things can happen. It can change a person. We want a progressive recovery. Stay positive. We want the family involved. You don't want to tell the patient to stay positive, though, right? But you want to be positive for them. But you want to keep that therapeutic communication. It's okay to say, this sucks. This is horrible. This sucks. This is hard, Don't say, everything's going to be okay. All right, we're going to go over brain tumors. We just have a few more slides. Brain tumors originate from the brain tissue. Primary, secondary is metastatic brain from a primary lesion. So a lot of times you'll see somebody, they have breast cancer and all of a sudden they have brain cancer. So that would be kind of a secondary. It's metastatic. All are deadly if not treated. They can definitely cause increased ICP because the tumor occupies the space, right? Just like the hematoma did. It occupies that space that we have to keep those percentages. These are just some names of the different types. You have a glioma, glioblastoma, astrocytoma, meningioma. I wouldn't spend a lot of time reading and learning about those. Just kind of know that the glioblastoma is your most invasive malignant. These are just some good pictures. Manifestations vary. It depends on the location, the tumor size, the rate of the growth of the tumor. And these are just some examples here. This is one, they're different areas of the brain. What are you going to see with brain? Well, you're going to see a headache. Remember I said, of course you're going to have headaches when you're having brain trauma, but when you're thinking about a headache with brain tumors, that's sometimes your first symptom, and it's worse at night because when you're laying down, ICP goes up, right? It can be dull, constant, or throbbing. Definitely they could have seizures, vomiting, loss of emotional control, confusion, and memory loss. And of course depression. Did I have that on there? But if I didn't, you can add, oh, it's on there. Yeah, depression. Diagnostics, MRI, and often they'll do a PET scan to see if there is metastasis or see if there's other organ involvement. So MRI or PET scan. Definitely an MRI, and then the PET scan usually later to see if there's any other organ involvement. Your treatment goals: identify the tumor, remove or decrease the tumor mass, prevent or manage ICP, increased ICP, right? So those are your goals. Identify the underlying cause, right? Remove or decrease the tumor mass and prevent or manage increased ICP. Of course, we want surgery to take it out if possible. And then radiation, sometimes after. And then they might do medications to shrink it, steroids, corticosteroids, anti-seizure meds, and chemo. All your regular treatment for cancer. So do y'all remember what kind of, are these brain tumor patients, are they more prone to SIADH or DI? SIADH, right? So what would you see? Weight gain. Serum, sodium maybe like 125, so that's kind of low, right? And then your specific gravity 1.040, so kind of elevated. So a lot of times you'll see low urine output, so SIADH with a lot of times with the brain tumors.
I just got it.
Mm-hmm.